Let's get on to the first part of the upcoming module. So this module has 4 parts to it. Cardiac drugs, pulmonary drugs, antihypertensives, and anti-hyperlipidemics. This first stretch, we'll call this part 1. This will be cardiac medications and pulmonary medications. I'll probably do a separate video lecture on each section. Sorry, I don't want to make them too long. The chapters really aren't that bad, actually. I was surprised when I read them. I thought they would be horrible. So I'm going to go over some things with you. Cardiology is kind of my background, and where I practice medicine, I have a very close relationship with many of the cardiologists from the Arkansas Heart Hospital, outstanding individuals, and they've taught me quite a lot. So, in the book, Chapter 6 on page 85, drugs used in the treatment of cardiovascular disorders. Now, first things first, I practice in the acute setting in a hospital, so what I'm not going to do is get all ER or Dr. House on you about all the crazy drugs and cardiac situations we can get into in the hospital, because we're thinking right now of a general, primary clinic, maybe an urgent care clinic. I want you to have an understanding. Let's not worry about people who are crashing with 3 different arrhythmias and whatever. Anyways, so basically things you're going to treat. Number 1 in Arkansas, neck and neck, are typical coronary artery disease and heart failure. They both go hand in hand. Many times one causes the other, meaning coronary disease will cause heart failure. You can have heart failure without coronary disease. There's also arrhythmias. Very common arrhythmia is atrial fibrillation. Excuse me. Many of those things you may initially detect in a patient. You may send them to a cardiologist. They may come to me in the hospital for the first time for treatment, and then once I've treated them, I'm going to refer them back to you, the primary provider, for continued management. And it's perfectly within your means to do so. They don't necessarily have to see a cardiologist all the time. So the first section in the book talks about heart failure. Now, there are types of heart failure people talk about, and you've gone over all this in pathophysiology in undergraduate school, and I think pathophysiology is next semester. We'll go over it more. I think I'll be teaching that as well. If not, sorry for that, fellow. Anyways, heart failure, systolic and diastolic. Systolic heart failure is the worst, typically related to heart muscle death. Someone has had a myocardial infarction, a part of their heart has died, just like a stroke, and it no longer works, so it has reduced the left ventricle's ability to pump blood substantially in most cases. People with what I would call mild systolic heart failure have an ejection fraction around 40 to 45%. They're not too bad off. Those people are the ones that got lucky, and you really want to help them out to keep them from getting worse. Now, when you get down to 35 to 40, and especially anything less than 35, these people are very symptomatic. They're going to be in their cardiologist's office a lot, but they're going to be in your office too, because chances are they've got multiple medical problems, and they all overlap. These people are probably diabetic. They probably have hypertension. Many of them may have renal disease, lots of different things that they're going to have all these specialties that they're going to see, but you're the primary provider, so you have the ticket. You are managing all of it at once. So diastolic heart failure is more of an issue where the heart cannot relax completely to pump blood. You'll see this a lot with pulmonary issues where the pulmonary arteries are so backed up, and always think of heart failure in terms of plumbing. The pulmonary arteries are so backed up that the heart is not relaxing properly to pump blood, so it's actually pumping less blood. Anyways, more about the pathophysiology later on. Let's talk about the drugs. So, for this course, let's assume that we're not diagnosing anyone with heart failure. We already have the diagnosis. How are we going to treat them? Heart failure is graded in a few different ways. The way that's most commonly used is called New York Heart Association, or NYHA, and it's 1, 2, 3, and 4, and it's based on symptoms. Okay, now that does not necessarily tell you how to prescribe medications, but it will help you with billing, so always remember that. I had a mentor who once told me, when it came to heart failure, there are 3 P's. You want to park, pump, and pee, like P-E-E, urinate. And it really makes a lot of sense. Park. We want the person to rest, not to exert themselves so much, because that's what causes the symptoms when there's too much demand for the heart. Pump. We want the heart to pump better. And then P, fluid offloading. Reduce the load of pressure on the heart, diuretics. Okay, so mainstays of heart failure. Number 1, beta adrenergic blockers. Now, there are 2 that I use mostly, and they're 2 of the more commonly spoken about ones in the book, which are metoprolol and carvedilol, or also known as low pressure and Coreg. Now, there's research that says that Coreg is better. It's more cardioselective than metoprolol. However, that research also says we don't really know how it works, we just know it does. If you think of it in terms of potency, Coreg is more potent than metoprolol. If you're giving a patient this dose of metoprolol, that dose, then let's say that's 25 milligrams. Well, let's say you're giving someone 25 milligrams of Coreg, it's actually that big. It's much more powerful. Anyways, that's besides the point. The other medication that the book talks about, which is not used all that often in a lot of settings, a lot of the cardiologists I know use it quite a bit, but not for the treatment of heart failure, and that's digoxin. It used to be a mainstay. It also helps improve contractility and relax the heart. It's very inexpensive. This drug's been around for 300 years. It comes from a plant, like most medications. And it's still quite effective. It still has its place. It's just that a lot of the beta blockers, such as Coreg, are typically shown to be superior. So you won't see very many people on digoxin for the purpose of heart failure management. But remember, it is an option. And for the purpose of this quiz, it is talked about a little bit at length in the textbook. So, digoxin, remember what we spoke about in the last lecture, therapeutic windows. Digoxin is a drug that always comes to mind when I think of a therapeutic window. It has a narrow therapeutic window. If you don't get enough, it doesn't work. If you get too much, it'll make your heart stop. Now, for the importance of this course, I want you to remember simply that it's something you want to monitor because of the narrow therapeutic window. Now, here's what a cardiologist told me, who studied with one of the cardiologists who did the original study to bring digitalis to the United States from Europe. He said if a patient is on digoxin and it's not working, they're simply not on enough digoxin. That kind of breaks the rules in some ways. Well, what if my digoxin level is 2.5 because the high end is 2? Well, I don't know. For this course, remember that too much is no good and too little is not enough. Remember, perfect world scenarios. Okay. Also, digoxin, remember, for digoxin toxicity, people who are symptomatic, who are having very abnormal heart blocks from it, and you will notice this, that there will be quite a gap between the QRS complexes where the T wave and P wave will be very close together. It's not always the case, but it is a classic presentation. Anyways, this medication has an antidote, a reversal agent, called Digibind. I know everybody remembers that. You may see it on a test question. Quiz. We don't take tests, we take quizzes. Okay, so the beta blockers. They play two roles. Number one, they decrease the neurohormonal stimulation. In other words, your adrenal glands are pumping out all the stuff that makes us anxious, excited, and when we get anxious and excited, our heart pumps faster a lot of times, but not necessarily